I want you to imagine, just for a second, that you need to pick up a heavy cardboard box from the floor.
Right. Something we all do, pretty regularly.
Exactly.
Yeah.
And you probably know the drill. You walk up to it, you plant your feet wide, bend your knees, keep your back perfectly straight, and you lift.
Because it's predictable. I mean, the box is a fixed shape, the weight is evenly distributed, and, well, it doesn't fight back.
No, it doesn't. It's this perfect, obedient object. Geometry and physics are just working entirely in your favor because the center of mass, it never shifts.
Right. It's a completely static load.
But now, and this is the core of our deep dive today, I want you to imagine picking up a human being.
Which is a whole different ball game.
Completely. Imagine someone who might be unconscious or, in severe pain. Someone who shifts their weight unexpectedly or has limbs moving independently.
Or maybe they have fragile skin, or they're connected to IV lines and catheters.
Yeah, suddenly that simple task of lifting is infinitely more complex, unpredictable, and frankly, dangerous.
It is a fundamentally different physical reality, and yet for the better part of a century, we actually trained medical professionals to treat those two scenarios identically.
Which just sounds so crazy now. But welcome to today's deep dive. We're taking a stack of really fascinating sources, historical texts, biomechanical guidelines, occupational injury data, and modern nursing frameworks to explore this concept of body mechanics in nursing.
And it is such a critical topic.
It really is. Our mission today is to uncover a massive systemic flaw in how we historically taught people to lift. We're looking at how the modern approach has totally shifted to focus on protecting both the caregiver's back and the patient.
Right, we're talking about safe patient handling, and why everything we thought we knew about safely lifting a person was completely upended, mostly in the early 2000s.
It's a story about physics, sure, but it's also about human biological limits, workplace culture, and, realizing when a universally accepted best practice is actually causing profound physical harm.
Yeah, doing the exact opposite of what it's supposed to do.
Okay, let's unpack this. Because to understand why the rules of lifting patients failed so spectacularly for decades, we first have to look at where those rules actually came from.
And surprisingly, they didn't originate anywhere near a hospital floor.
No, which is the wildest part to me.
Right. Body mechanics, as this formal set of instructions, was entirely imported from the factory floor.
Like manufacturing.
Exactly. Its intellectual ancestors are industrial ergonomics and time and motion studies.
The efficiency experts, basically.
Yeah, exactly. So in the early 1900s, you had these pioneers like Frank and Lillian Gilbreth.
Right.
Frank was a building contractor, and Lillian was an industrial psychologist. And they became really famous for studying how workers could perform physical tasks with the absolute least amount of wasted motion and physical strain.
Didn't they actually go onto work sites and film people?
They did. They filmed bricklayers, analyzing every single micro movement. They figured out how to arrange scaffolding and bricks so a worker didn't have to bend over as much. Yeah, they actually reduced the standard 18 motions of laying a brick down to just 4.
Which makes total sense for building a wall. It's highly repetitive, predictable work. And this really ties into the origins of ergonomics itself, right?
It does. The term actually traces all the way back to 1857.
That is way older than I thought.
Right. A Polish scholar named Wojciech Jastrabowski coined it by combining the Greek words ergon, meaning work, and naimos, meaning natural law.
Natural law of work. I like that.
Yeah, but the modern discipline really took shape in the mid-20th century. It was heavily driven by military and industrial safety needs during and after World War II.
Ah, that makes sense.
They were figuring out how to safely and efficiently move crates, artillery shells, heavy machinery without injuring the workforce.
So by the mid-1900s, nursing schools look at this industrial science and just decide to adopt it wholesale.
Pretty much, yeah.
They were essentially teaching student nurses to lift human beings the exact same way warehouse workers were taught to lift wooden crates.
Exactly. Wide base, straight spine, bend the knees.
But that 20th century mindset rested on a pretty catastrophic assumption, didn't it?
A huge one. It assumed that a patient could be treated like a predictable payload.
Right, like a box doesn't suddenly lean to the left because its hip hurts.
No, or resist you because it's confused about where it is, right?
Exactly.
The old training assumed a fixed symmetrical load. The idea was, if you lifted it with the prescribed posture, you supposedly wouldn't get hurt.
But real patients are none of those things.
Not at all. Their weight distribution varies enormously based on their medical condition. You just cannot square up to a patient in a hospital bed the way you square up to a pallet on a loading dock.
Because human bodies are nothing like cardboard boxes.
Mhm.
So attempting to move them requires us to look at the literal physics and anatomy of what happens to the human spine under a shifting load.
And the physics there are just brutal.
Yeah, they really are. When we look at the first principles of body mechanics, it rests heavily on two things: center of gravity and base of support.
Right, so you are most stable when your center of gravity is directly above the area bounded by your feet.
So if you widen your stance to shoulder width, you lower that center of gravity and enlarge the base.
Exactly. It's like setting up a tripod instead of trying to balance a broom on its handle. You're artificially giving yourself a wider foundation to absorb any sudden shifts in weight.
Okay, that part makes sense, but
Right.
then there's the muscle aspect,
Yes, you always have to prioritize large muscle groups over small ones.
meaning your legs.
Right. The muscles in your thighs and glutes, your quadriceps and gluteals, those are massive, resilient structures built to generate force.
But your back muscles aren't.
Exactly. The erector spinae muscles of your lower back are not built for that. If you bend forward at the waist with straight knees and try to pull someone up, your upper body acts like a long lever arm.
Oh, that sounds bad.
It is. This multiplies the effective weight of everything you were lifting, and it sends dramatically higher compressive and shear forces right into your lumbar spine.
Specifically those lower discs, right?
Yeah, particularly the L4, L5, and L5S1 intervertebral discs.
And for you listening, just to picture this, those L4, L5, and L5S1 discs are the hinges at the absolute base of your spine. They act as the primary fulcrum for your entire upper body.
So when you lean over, those tiny discs bear the brunt of the entire load.
And then there's that other rule they always taught: keep the load close to your body. Let's visualize this for a second. Imagine holding a 30-pound weight, like a heavy dumbbell, hugged tightly right against your chest.
It's heavy, but you can manage it.
Right. But now try holding that same 30-pound weight straight out in front of you at arm's length.
That is an entirely different feeling.
Your arms are now acting as long lever arms, multiplying the weight, and suddenly your lower back is just screaming.
Right, because that rotational force on your lower back is called torque, and torque increases with the distance from the pivot point. The further the weight is from your spine, the greater the torque.
And this exact mechanical reality was formalized by the government, right?
Right, yes, in the Anaios lifting equation. It was developed by Thomas Waters and colleagues, first published in 1981 and then revised in 1991.
And what does it actually do?
It calculates a recommended weight limit for manual lifting. And it factors in several really strict variables: the horizontal distance of the object from the body, the vertical lift height, how often you're lifting, and the quality of your grip.
So looking at that equation and all those variables, what is the maximum safe limit they came up with? Because it's staggeringly low.
It really is. Under textbook perfect conditions, meaning the object is close to the body, there is zero twisting, it is lifted smoothly from floor to waist height, and it's done infrequently. The absolute maximum recommended weight is about 51 pounds.
Wow, only 51 pounds.
Yeah, just 23 kilograms.
Here's where it gets really interesting. 51 pounds under perfect conditions. So it becomes a glaring mathematical impossibility to ask a nurse to manually lift a 150-pound adult who's lying awkwardly in a bed.
It's just not possible to do safely because the real bedside geometry is never ideal.
Right. Nurses are reaching across wide mattresses, lifting at awkward heights, trying to reposition someone who just cannot bear their own weight.
And that 51-pound weight limit drops sharply the moment you introduce distance, a poor grip, or awkward posture.
And what about twisting? Because you mentioned zero twisting earlier.
Oh, twisting is the absolute worst offender in the Anaios H equation.
Because if you twist your torso while holding that weight, you're basically grinding those spinal discs together.
Exactly. Rotating your trunk while bearing weight, like reaching across a bed to lift a patient while your feet stay planted facing another direction, it creates shear forces across those lower spinal discs that a straight line lift just doesn't.
So how are you supposed to turn?
The biomechanical solution is to pivot with your feet. It's a maneuver called a step turn rather than twisting at the waist.
Or better yet, pushing or pulling the load instead of lifting it vertically, right? To keep those larger leg muscles engaged.
Precisely. Push, don't lift whenever possible.
But even with a step turn, if the mathematical limit of human biomechanics is 51 pounds perfectly balanced, Asking a nurse to move a 150, 200, or 250-pound patient means they're being asked to lift triple their mechanical limit or more every single day.
Often multiple times a shift.
Something has to break. And when we look at the occupational data from the sources, it wasn't the beds breaking, it was the nurses.
Yeah, the math just caught up with them, creating the slow-motion occupational crisis. U.S. Bureau of Labor Statistics data tracked over decades paints a staggering picture here.
What did the data show?
Nursing assistants and registered nurses consistently ranked among the occupations with the highest rates of disabling back and musculoskeletal disorder injuries requiring days away from work.
I mean, that puts them on par with or even exceeding physically punishing trades like construction laboring, heavy manufacturing, warehouse work.
Exactly. And overexertion in lifting and repositioning patients is consistently cited as the leading cause of those injuries.
So for decades, if a nurse got hurt on the job, say they pulled out their back trying to save a patient from sliding out of the chair, did the hospital system just blame the nurse?
Sadly, yes. That was the traditional camp throughout most of the 20th century.
They were told their technique was flawed, or they simply weren't physically fit enough for the job.
Right. The belief was that proper technique, if taught and reinforced, was the primary defense against back injury.
Wow.
Therefore, if an injury occurred, the assumption was it reflected a lapse in that technique or just insufficient personal strength.
It assumes that if you just hit the gym and build up your core, you can deadlift your way through a 12-hour nursing shift safely.
Which is a huge misconception.
Yeah.
The biomechanical research makes it clear spinal injury from patient handling isn't just about failing one single heavy lift.
What is it about then?
It's largely a function of cumulative microtraumas.
Microtraumas, like tiny amounts of damage adding up.
Exactly. Every time a nurse exceeds that 51-pound limit, tiny structural damages occur in the spinal discs and the supporting tissues. Over a career, those microtraumas accumulate, eventually leading to a catastrophic failure, which is often triggered by a seemingly minor movement later on.
Like just bending over to tie a shoe and your back goes out.
Exactly. Baseline fitness reduces the overall risk profile, sure, but it does not eliminate it. You just cannot out-fitness the laws of physics.
That makes total sense. So this paradigm shift really seemed to gain momentum in the early 2000s, right? You had figures like Audrey Nelson.
Yes. Dr. Audrey Nelson, a PhD and registered nurse affiliated with the U.S. Department of Veterans Affairs.
And what was her role?
Through the VA's Patient Safety Center of Inquiry, she led the development of evidence-based algorithms for safe patient handling. She's a huge pioneer here.
And organizations like the American Nurses Association and NIOSH, they started pushing the medical field to stop treating manual lifting technique as the primary solution.
They did. But the empirical data that truly changed the landscape arrived a bit later, in 2011, with the Cochrane Review.
This was led by the researcher Joseph Beek.
Right. Yes. They examined manual handling advice and assistive devices for healthcare workers.
And this is the part that is just wild to me. When they looked at the data, comparing cohorts who only received posture training versus those who received mechanical equipment, the posture training failed completely as a standalone intervention.
It failed completely. It's one of the more sobering results in occupational nursing research. Verbeek's team analyzed dozens of studies.
And what did they find?
They found that all those hours of in-service training, all those posters telling nurses to keep a straight back and bend their knees, it produced little to no measurable reduction in back injury rates on its own.
Not at all.
The intervention only showed a statistical benefit when it introduced mechanical lifting equipment combined with organizational policy changes.
By policy changes, you mean actually reducing the frequency and the weight of manual lifts through systemic rules.
Exactly. This birthed the modern framework we use today. Safe Patient Handling and Mobility, or SPHM.
The emphasis completely shifted, right? From how do I lift this patient correctly to how do I avoid manually lifting this patient altogether using technology?
Exactly. The focus became the equipment.
But shifting from fixing the nurse's posture to changing the whole hospital system with machinery that had to create friction.
Oh, massive friction.
And it leads to some really persistent myths about what modern patient handling actually looks like today.
Yeah.
Like, one major misconception from the sources is about these no-lift policies.
Yes, this is a big one.
People hear that and think, wait, if hospitals implement no-lift policies, does that mean nurses aren't allowed to physically touch or assist patients anymore?
What's fascinating here is how the term no-lift gets so widely misinterpreted. A no-lift policy does not mean zero physical contact.
Okay, what does it mean?
It specifically means staff should not manually lift a patient's full body weight unassisted. Nurses are still using their body mechanics every single day for guiding, stabilizing, and repositioning patients.
They're just applying those mechanics to operate the equipment, rather than acting as a human forklift.
That's a great way to put it. Modern equipment physically neutralizes the weight of the patient.
Like those friction-reducing slide sheets, right?
Yes, they use ultra-low friction materials, often silicone-coated.
How do they work?
When you place them under a patient, pulling them across a bed goes from this heavy, high-torque drag to a smooth glide because the coefficient of friction is nearly eliminated.
That's brilliant. And then you have Hoyer lifts and ceiling-mounted lifts, which use hydraulic or electric motors.
Right, they provide the mechanical advantage to hoist a patient entirely, allowing the nurse to safely guide them into a chair.
Which brings up another critical point from the sources. Body mechanics and this mechanical equipment, it isn't just about the nurse's back.
No, not at all.
It is a shared safety issue.
Exactly. Proper technique and the use of safe patient handling equipment protect the patient just as much as the caregiver.
Because poor manual lifting technique can cause severe damage to the patient too.
Absolutely. If you try to manually haul an elderly patient up by their arms, the sheer force can cause skin tearing.
Which is incredibly dangerous and prone to infection.
Or it can cause severe joint damage. It frequently leads to subluxation, especially in neurologically impaired patients.
What exactly is subluxation?
It's when a joint, often the shoulder, during a lift, partially pops out of its socket and snaps back in.
Oh, that sounds awful.
It is an incredibly painful injury that severely delays recovery. Furthermore, manual lifting just drastically increases the risk of bruising, or worse, dropping the patient during a transfer.
So the modern framing is all about shared safety, protecting your back and your patient simultaneously.
It's a win-win.
But the sources also highlight a pretty tragic systemic failure during this transition period. You had hospital administrations that spent heavily on posture training, bringing in consultants to teach body mechanics.
But they absolutely refused to allocate the budget to buy the mechanical lifts or hire enough staff so two people could assist.
Right, and the results of that half measure were entirely predictable.
Yes, those hospitals saw persistently high injury rates and sky-high staff turnover. Nurses frequently cite chronic back injury as a primary reason for leaving bedside practice altogether.
It's literally driving them out of the profession.
Exactly. Workplace safety researchers describe this slow-motion attrition as a major, underappreciated driver of the ongoing nursing shortage.
Because it's distinct from emotional burnout or disputes over pay.
Yeah, it is the literal physical destruction of the workforce.
If a hospital system views safe patient handling programs, buying the equipment, maintaining it, ensuring staffing ratios allow for two-person assists as merely a safety compliance line item to ignore, they lose their staff.
And that's why modern healthcare policy is increasingly treating these equipment programs as vital workforce retention investments.
They literally have to keep their hospitals running.
Right.
So what does this all mean? We have evolved from blaming the individual for having bad posture to understanding that systemic safety and biological physical limits really matter.
And the stakes got so high that it actually became a matter of law.
Right. Starting in the mid-2000s, states like Texas, Washington, and Ohio passed safe patient handling laws.
These laws require hospitals to develop written programs and purchase lift equipment rather than relying solely on telling nurses to just bend their knees.
Which is a huge victory. But moving from the hospital floor to everyday life, understanding these physical realities changes how you approach movement in your own home, too.
Oh, absolutely. The underlying physics, your base of support, your center of gravity, keeping loads close to your body, pivoting your feet instead of twisting your spine, these apply universally.
Right. Whether you are a home caregiver assisting an aging parent out of bed, a parent lifting a heavy toddler out of one of those ridiculously deep car seats,
or just helping a friend move a couch up a flight of stairs.
the physics remain identical.
Yeah.
And that 51-pound recommended limit from the IOH equation, that applies to all of us.
It really does. As populations age, and as average body weights have risen over recent decades, the mismatch between our safe manual lifting limits and the actual weight of the people we might need to help has only grown starker.
Which really reinforces why equipment-based solutions, modifying our environment, and frankly, just asking for help are the only safe ways forward.
Exactly.
So we come back to where we started. The difference between lifting a box and lifting a human being.
The box is predictable.
But the human is infinitely complex. And protecting them and ourselves requires more than just geometry.
It requires acknowledging our true biological limits.
Thank you for joining us on this deep dive. But before we go, we want to leave you with one final thought to mull over. If human biomechanics strictly limits our safe, unassisted lifting capacity to about 50 pounds under perfect conditions, how might we need to totally redesign our everyday environments?
That's a great question.
Think about the heights of our cars, the depths of our home furniture, the layout of the spaces we live in every single day. How do we need to rebuild our world to account for our true biological limits, rather than our perceived strength?
Definitely something to ponder.
Something to think about the next time you bend down to pick something up. Until next time.